Welcome to Raaonline. Today we are going to discuss about the topic on anti-adrenergic drugs, and especially I am going to discuss you with the alpha blockers. What do you mean by alpha blockers? They are the drugs that inhibit the interaction of catecholamines. So you know the catecholamines like adrenaline, noradrenaline, okay, and other synthetic varieties also there. And they inhibit the interaction of these catecholamines or other sympathomimetic drugs with the adrenergic receptors. So the adrenergic receptors they will be taking in a different session. What are the different adrenergic receptors? But anyway, I will be taking you through the little bit of flow chart. I will show you in the next slide. And it can be otherwise called as sympatholytics. So they abolish the response to the stimulation of the sympathetic nerves. So this is the adrenergic receptors, okay. You classify into alpha receptors, beta receptors and dopamine receptors, okay. These are all catecholamine related things, so that is why it is called as adrenoceptors. And you have got adrenergic neuron blocking drugs. This I have already dealt in the topic on anticholinergic drugs. So coming to the adrenoceptor antagonist, you have got alpha receptors, where it can be subdivided into alpha 1A, 1B and 1D, and this alpha 1 subtypes, they are more specifically seen in the blood vessels. So that's why when you stimulate this alpha 1 receptors, it leads to vasoconstriction. Whereas this alpha 1A as well as alpha 1D, they are more specifically present in the bladder, okay, urinary bladder. So that is why in case of any bladder, the benign prostatic hypertrophy, all those things, you can use a specific alpha 1 or 1A or 1D antagonist can be used. Similarly, alpha 2 and alpha 2B sometimes in platelets and other things. I will show you in the next slide the places where they are situated. Coming to the beta receptors, beta 1, 2 and 3 is there. I am not going to discuss about this. It is a separate talk actually on beta adrenergic drugs as well as beta blockers. Then dopamine also I am not going to discuss here. Since it comes under the catecholamine, so I have been mentioning under these are the various antagonists that can act on these particular receptors. So as I told you, the slide, this is the presynaptic nerve terminal, this is a sympathetic nerve ending where the norepinephrine is the neurotransmitter. So the most common neurotransmitter present in the sympathetic nerve ending is the norepinephrine, except in adrenal medulla, where the adrenaline is a neurotransmitter released from the sympathetic nerve ending. That is the main difference. So what happens, how this norepinephrine is synthesized? So tyrosine, okay, again in the presence of dopa and forms a dopamine, and dopamine is stored in the vesicles, okay, and similarly the norepinephrine is also synthesized from the dopamine, okay, and finally it is stored in the vesicle. And once when the stimulus comes through this presynaptic nerve terminal, the norepinephrine will be released in the synaptic cleft and acts on the postsynaptic receptor. Either it is a alpha receptors more commonly. So this is a normal how the synthesis, storage and release of the neurotransmitter, especially in the norepinephrine in the sympathetic nerve ending. So coming to the alpha adrenergic receptors, the places where they are located. For example, alpha 1 subtype, they mainly present in the vascular smooth muscles, and that is why it can increase the contraction of the vascular smooth muscles leading to vasoconstriction. Thereby it can increase the blood pressure. So that is why your adrenaline, norepinephrine acting on this alpha 1 receptors leading to high increase in the blood pressure. Similarly, the salivary glands, they increase the secretion, whereas the radial muscle of the iris, okay, I think we talked about in the cholinergic chapter, the muscarinic receptors M3 is present in the circular muscle of the iris, whereas the sympathetic one, the alpha 1 receptors is present in the radial muscle of the iris, where they increase the contraction and lead to dilatation of the pupil. That is one main difference. Similarly, as I told you, urinary bladder neck alpha 1A is a subtype present in the urinary bladder neck, and then similarly in the vas difference. So what happens when when this alpha 1 is stimulated in that particular area, it leads to increase in the contraction of the trigone here, okay, and similarly when there is an increase in the contraction of the vas difference, it leads to increased ejaculation, okay. Then splenic capsule, you have got a alpha 1b subtype, where if there is a contraction of the splenic capsule, so naturally they increase the red blood cell release. So more RBCs will be released in the circulation. So then it is also present in the hippocampus, and prostate alpha 1d subtype is present. So all these subtypes is more important, because when we are going to discuss the individual drugs in the coming slides, you need to know which drugs can be specifically used in the treatment of benign prostatic hypertrophy, which drug can be used in the treatment of as an antihypertensive drug. Okay. So alpha 1d is very important for prostate, alpha 1a in case of bladder neck. Then coming to the alpha 2 subtype, it is mainly presynaptic in the central nervous system. So it acts whenever you stimulate the presynaptic alpha 2 receptors, either in the adrenergic nerve terminals or in the cholinergic nerve terminals, it will decrease the norepinephrine release. That is why clonidine, which is one of the important antihypertensive drug used those days, it acts as a presynaptic alpha 2 agonist, and thereby it decreases norepinephrine release, and thereby it is acting as an antihypertensive drug. Similarly, in the postsynaptic, in platelets, brain, some places in the brain, and beta cells of the pancreas, the alpha 2 is present. So when you stimulate that, it causes decrease in the aggregation of the platelets, okay, and it causes decrease in the insulin release from the beta cells of the pancreas. So coming to the classification, so we are going to talk about the non-selective alpha, that means both alpha 1 and alpha 2 it blocks, that is non-selective. Selective means either it blocks the alpha 1 receptors, okay, or it blocks the alpha 2 receptors.